So, the mental status exam. I know everyone in here knows how to do a mental status exam. However, there are some things to keep in mind with neurostatus exams. Mental status exams are really important for any kind of neuropsych assessment, because often what we're doing is looking at how the person presents. So specifically, the MSE mental status exam is the psychologist's ROS. What does ROS stand for? Review of systems. That's a medical term. All your medical doctors, when you go in and they check your blood pressure and they look in your throat and they look in your ears and they poke and prod you, that's their MSE. Our MSE looks a little bit different because, well, you know, we're psychologists. We don't want to poke and prod, at least in the brain. And so ours looks like this. These are the different areas that you're going to be looking at in a mental status exam. I'm going to cover these fairly quickly because I know all of you know how to do a mental status exam. But first and foremost, if someone comes into your office and they have headaches, they're nauseous, they're vomiting, send them to an ER immediately. They might be having a stroke. They might have had a head injury last night and have a brain bleed. They might just have the flu, but whatever it is, don't test someone who's like that, right? Also, if someone has sudden changes in their mental status, if they are scheduled to see you and their wife brings them in and their wife says, wow, doctor, you know, 2 days ago he seemed fine, but now he's stumbling around and no, he hasn't been drinking, send him to an ER immediately, okay? Don't test him like that. And also, you know, if you're going to be doing neuropsych screening, this third piece isn't as important, but if you're going to be doing a full neuropsych assessment, and if you're doing any neuropsych screening, it's good to have medical cooperation, all right? So if you can have any collateral, specifically from a physical done in the last year, then you're golden. But you really want to get that physical from the last year just to see how they've been with their review of systems. Appearance, you want to look at their gait. How are they walking? Are they walking with a shuffling gait? Are they walking with a drunken sailor gait? All of these could mean something different, all right? If they are walking in any strange way, that could be indicative of something called ataxia. You're also looking at their eye contact. Their eye contact is important because if they're not able to make eye contact, it could mean that they're depressed. It could mean any number of things, but you want to make note of that. You want to make note of any unusual mannerisms. And also, you want to make note of any assistance devices. So are they walking with a cane? Are they wearing glasses? Are they not wearing glasses, but they told you they needed glasses? That might impair your test results. What about hearing aid? You know, if they said, you know, I need a hearing aid, but I haven't been able to afford one, doctor, then you need to make reasonable accommodations. Speak louder. Or at least note in your report that these aids were not present but were stated that they needed. Because that might be affecting your test scores. Orientation, well, we're looking, you've all heard of orientation times 2, 3, 4, 5. I never put that in a report. I always put the person was oriented to date, time, day, place, because a judge normally doesn't know what oriented times 3 means. I always keep in the back of my mind, not to disparage anyone from Starbucks, we all love baristas, but does the guy at Starbucks know what you're talking about? Because that guy from Starbucks might be the juror that's sitting in the jury box that you now have to answer to because your report goes into their hands and they're like, I don't know what this O times 3 is. So spell things out. One of the main things for neuropsych I like to ask with regard to orientation is, do they know why they're here being tested today? What's my role as the examiner? What's their role? If they have no clue why they're being tested, then explain it to them. It also goes into informed consent. So you need to know all of that. All right, now what about speech? How articulate are they? Are they speaking with slurred speech? Slurred speech could mean anything. It could mean that they're currently drunk, or it could be aphasia, and we're going to be talking about it a little bit later as well. With regard to speech, it kind of goes speech and thought content. You're wanting to look at any kind of perseverations. Are they repeating themselves over and over again? That's important. Also, anytime you have someone who's English as a second language, you want to note that. And you want to note how long have they been speaking English if you're administering tests in English. You want to note if they're bilingual, if they're fluent in English as well. What about thought process? Looking at thought process versus speech. It can sometimes be difficult to distinguish between speech and thought disorders, but the kind of rule of thumb is slowing, motor slowing. So you're looking at that, and speech can be also portioned out by evaluating for confusion and mental confusion, appropriate associations, if they're logical, if they're thought blocking, and if they're confabulating. So if it's speech, it will be something in the quality of speech. And when we talk about aphasias, we'll talk about aphasias and the different quality of how that looks, what sort of things to look for in there. Attention, concentration, memory, those are things that we're actually formally going to be testing for. But also attention span, you can look at attention span, you can look at what's the test that you normally use in the mental status exam for attention? Digit span. And that could be something that you can just throw out there. You don't actually need to pull it from the Weiser-Watson. You can just say it. And then another thing is you can also have them spell their name. Spell your name, unless it's only 3 letters long. Spell your name backwards, because their name is something that's overlearned. That's attention, but also goes into executive functioning and processing. We're going to get into that in a little while as well. For memory, looking at autobiographical memories versus recent events. So you're looking at episodic memory, we're going to go into memory in a little while, versus working memory and recent memory. You're looking for specific details when you're looking at memory. You want to know specifics about their past. Are they able to come up really quickly with what happened to them? Or are they kind of making it up on the spot? Though it's a really good place also for collateral information. So you can cooperate with the wife or mother if this actually happened in their past. Things to ask them about are salient memories. Usually, rule of thumb, for men it's their first job. For women it's their wedding date. Yeah. Can you tell me about your first day on the job, or what was your first job like? Can you tell me about what your wedding date was like? So that's looking at specific types of memory. You're also looking at cognitive functioning, and cognitive functioning is this huge umbrella term, and we're looking at many, many different areas under cognitive functioning. You're looking at abstract reasoning by what? What would you say for abstract reasoning? Similarities and proverbs, yes. So similarities, how are apples and oranges alike? Also, draw a clock, and we're going to talk about clock drawing a little bit later. So we're also looking at their emotional state. What's the difference between mood and affect? What's mood? How they feel. Their subjective experience. What they say they're feeling. How are you feeling today? If they say, I'm feeling fine, and they're crying, that's really important to note, because affect is your experience of them. If they are laughing inappropriately, you're talking about the death of their dog and they're giggling manically. That's something to know. So you can talk about how mood and affect are congruent or incongruent. Also, special preoccupations and experiences. It's a report of bodily experiences or concerns if they have somatic concerns. And there's no reason to have somatic concerns. Or if they have suicidal ideation, they're preoccupied with that. That's really important to take note of. And then insight and judgment. Insight is really a patient's understanding and appreciation of their condition. What are their expectations of the future? Where do they see themselves in 5 years? That goes to looking at insight. Whereas judgment is realistic insight. Do they understand the consequences of their actions? Do they have financial plans? Do they have any legal needs? Do they understand all of this? So all of this is really important to take into consideration. But what about medical problems? It's really important to look at possible medical problems, going back to the reason why we need their physical. But also, it's important to kind of be aware of what all of these look like. A couple of people were talking about, well, what if they come in intoxicated? Or worse, what if they're withdrawing from any kinds of drugs and alcohol? Let me give you an example. 38-year-old Caucasian male treated in an internship, presented, and I might have presented this one last time, with severe agitation and anxiety. He was seen 2 or 3 times. He kept on talking about sleep disturbances and how he just couldn't calm down. This guy, no meth history, clean as a whistle, worked as an accountant, Mountain Dew, yeah, a case of it a day. He didn't drink water, just a case of Mountain Dew. I cured that man by titrating him off the Mountain Dew. Yeah, I felt like such a great doctor. I was an intern at the time, it was fantastic. But for the first 3 or 4 times I was seeing him, I'm like, oh my God, this guy's manic. He's so anxious. You know, let's get him on something. Xanax. You know. No, all I needed to do was cut down on the caffeine. Other medical problems. Well, about a 70-year-old widower who comes in complaining of feeling cold all the time, but his body temperature's fine. He has crying spells, and he says that his memory's gotten worse and worse over the past few months. Hypothyroid, you know. The first thing our mind might go to is bereavement, you know, depression, but it absolutely could be hypothyroid. What about a 20-year-old construction worker who's referred to 14 months after a work-related injury? He's lost consciousness for 24 hours, but made a speedy recovery. He's now seeking SSI because he says he has seen things since the accident. He reported that he occasionally sees animals jumping out at him where there were none before, and he's afraid to go back to work. What are we going to rule out there? That's actually a very rare symptom of temporal lobe epilepsy brought on by head injury. So, that said, it comes back to the caveat, make sure you've ruled out everything, all right? And knowing that these are just screening assessments, make sure in your conclusions that you note everything that it could also be and that other future clinicians should be looking for. There are many other different considerations. As we just said, anxiety could be hypothyroidism, depression could be hyperthyroidism. It could also be cancer, brain tumor, heart disease. Malnutrition could come from anorexia, cancer, or drug use. So if we see someone who comes in emaciated, we don't necessarily have to think, okay, this person has anorexia or an eating disorder. We have to look at all of the different reasons. The bottom line is pay attention. Pay attention to all of the details that are out there. Ask for details. Ask for collateral information. Be a good historian. Get a really good clinical interview. With these screening assessments, we might only have a paragraph of testing, but we might have 3 pages of history. Right? And then get collateral information as much as possible. That's the bottom line.